Good afternoon, dear colleagues. Welcome, everyone. I'm Teresa Bombas. I'm gynecologist and obstetrician. I came from Portugal, and I'm the president of European Society of Contraception. We are here to have a webinar regarding a modern approach to contraceptive counseling. Counseling is a very important topic, and I'm here with two colleagues, very well known, Helena from Sweden, Helena Kallner from Sweden, and Rossella Nappi from Italy. We work together in this project that we will present to you, and all these materials from this project are you can follow this material and download these materials to use in your clinical practice. Before we start, I want to I want to share with you some practical questions. First, you have a button to put questions, and we do all the discussion in the end of the webinar, and you can put all your questions in. If you have time, we answer all the questions, and if we don't have time, we will answer later by email. And just a few words about European Society of Contraception. European Society of Contraception is a scientific society, not only for gynecologists and obstetricians, but all professionals, health professionals that work in reproductive health. We start to be a European society, and we are mainly a European society, but in present times, we have groups of providers, professionals that attend our meetings and collaborate with the society from countries outside of Europe. And you can apply for membership, individual or with your society. And if you apply, you have some benefits like a regular newsletter, free access to webinars, reduce in Congress registration fees, and what is very important, you have an open access to European Journal of Contraception and Reproductive Health Care. And you can, as I say before, you can affiliate it as an individual member, or you can affiliate your organization. And the affiliated organization have a representative in the board of ESC. And I want to have this opportunity to talk about our next Congress. Our next Congress will be in Belgrade, Serbia, next year between 6 and 9 of May, and it will be, like the other Congress, a huge opportunity to improve your knowledge and present your work. The registrations are now open, and you can submit your paper for a free communication or poster, and the deadline is the end of December. So let's move for the webinar, and I will start this webinar talking about why we realize that it's need to revisit the program of counseling. So this is a program that we develop for optimize the counseling in contraception. This is our conflict of interest from both of three that we will be speakers in this webinar, and I will show you why it's important to adaptate the contraceptive counseling for the modern times. In fact, normally since more than 10 years, we realize that when we work in contraception and to promote contraception, we decide and we realize that is not a prescription, but it's related with health, prevention of pregnancy, health benefits, and there's a lot of influence in the choosing of a contraceptive method. So it's no longer a two-way of conversation between a woman and a health professional, but is like changing and open discussion, taking in account with different things that are not related with health. So it's not more a prescription. And we know that when we give a prescription without involving the woman in the choice of the contraception, a majority of the women never go to the pharmacy and buy the contraceptive method. So we decide, because we do a lot of research for this program. We look at our guidelines, literature, medical publications. We look all these publications during the period of 2017 and 2014. We look at websites, and in fact, we have material enough to organize this program to say, okay, we must change the way of we do counseling, and we have to optimize and do it in a way that will be faster, because we have time for our appointments and we have to optimize our time. So all this research was optimized with expert contributions, and this expert contribution was me, Professor Rossella, and Professor Helena. And in the end, we organized a group of material slides and papers that you can use in your daily practice. So it's a three-step process, very easy to apply. The first one is about play and listen, understand the needs and expectations. So we don't start with medical conditions. We start with open questions. What are the afraid of the woman? What are the concerns? What they expect for contraception? It's like an open discussion to put the woman in a very comfortable position. Professor Rossella will talk in detail about this. The second is the discuss and recommendation of a method. So we explore the method, we explore the medical condition of the woman, we explore the sexual health and the sexual behavior, and we take in account with medical eligibility criteria, and we select a method. I will get in this topic in detail. And the third step is about normalize the choice and change. So it's about discussion, how it works, the contraception, when the woman have to come to make a discussion about the method that was her choice. And we talk about satisfaction and quality of life. And these three steps will be discussed and presented by Professor Helena. So I will stop here, and I will stop sharing my screen, and I will introduce Professor Rossella Nappi. She is coming from Italy. She is the actual president of World Society of Menopause. She is very well known in the area of reproductive health. Thank you, Rossella, to be with us, and I hope that we will see each other in Belgrade.
Yeah, thank you, Teresa. If you stop your screen, I can start
I
mine.
stop.
Hello to everybody. I hope you don't mind that I have kept my screen as president of the International Menopause Society because, I think that the counseling on contraception should be performed also in premenopausal women, and therefore women of any age can benefit from our work. And it has been a great, great pleasure to work with Teresa and Helena to develop this multi-step program. And you see in here, my part is really plan and listen. And the most important aspect of this way of studying the consultation is really to understand the needs and expectation. And if we do a good start with our patient, we will really create the foundation for open, ongoing discussion, and we will build a real trust. So, to do so, we really need to learn how to apply the following skills. First of all, the way we should adopt a question based approach to understand a woman's current needs, concerns, and expectation. And please keep in mind a woman, that individual woman, because this is very important to build the trust. Of course, we really need to be there empathic because if there is a conflict in the decision, this is a challenge for women. And if we are not able to really be empathic, women that will perceive that something is wrong and maybe they will go home and they will not do what we are discussing and suggesting. And then always we have to try to summarize the discussion without a judgmental approach or assumption, because we really need to help the woman to choose the contraceptive methods that really prefer. So how we can do the step one, question-based approach. It's very important to keep in mind that there are three major aspects that are in the literature out there. That the way we counsel women, they are not enough to fully capture women's need, concern, and expectation. And if we don't do so, we miss an opportunity to make a shared decision process that will help the woman to take the final decision. So our first goal is really to empower women to express their preference and any dissatisfaction, for example, with something that I've used in the past. I don't know what Teresa and Helena think about this, but my experience in my practice in Italy, it's really that if you start with the wrong methods, I remember when I was 16, I was on a pill, I gained 10 kilos. Then women, they don't want to go to take any pill whatsoever because they really distressed by that. So we really need to understand the previous experience. And then also what is important, we have to ask a question in which women, they have the perception that what we are discussing with them, it's really what they need. And I was lucky enough to conduct a research some years ago in which we show very clearly that those healthcare professionals who successfully uncover their patient hidden needs usually ask more questions than those who do not. And some people, they can argue, okay, we don't have much time in the consultation. This is the reason why we have to practice a program in which, in a very quick way, you can really ask those questions that are relevant to have more information for a better choice. And these doctors, they are also more likely to switch the patient from a current contraceptive to maybe a more suitable contraceptive method. So how we apply the evidence to everyday practice? The first thing, a clear, open-ended question, are proven to be the most effective means of uncovering a woman's contraceptive needs, enhancing the selection of the method, the satisfaction with the decision-making process, and of course, compliance over time, because an effective method should be really taken consistently and correctly. We know that the type of question, and I will give you some example, the one we ask significantly impact the quality of the conversation and a woman's ability to explore contraceptive options, express concerns, and make informed decisions. Of course, we have to keep in mind our checklist from a medical point of view. And we will ask some questions. We will try to figure out if there are some concern about applicability of the eligibility criteria depending on the medical history, but we have also to consider the psychosocial environment, preference for menstruation, which one are the reproductive goals, and it's very important to understand the family planning concept of these women, and of course also mood and sex and other interesting information that comes from the past history, and especially if women they are open-minded to change contraceptive methods, because this is another problem. Some women maybe they are not so fine with a contraceptive method, but they are afraid to change because they are afraid of potential consequences. So here are some little tips that can help. Look at this example. The healthcare provider, when do you plan to get pregnant? And the woman say, maybe in a few years. Of course, in this way you gain some insight, but you don't have so many information with a question like that. Whereas if you ask a specific question, and please have a look, this is more emotional. So you go into more, you are more in touch with the woman, and you ask, how would you cope with an unplanned pregnancy at this moment in time? And you see that the woman will answer, it would be a disaster, doctor, as I rent a small flat with friends. I could not afford to move out alone right now. So the woman is able to express her feeling, and she gives us a clear and strong reaction to the question, which tells you a lot about her situation, even on other aspects such as financial and living arrangement. And so for sure you understand easily that this woman is not ready for a baby, and the effectiveness for her is a priority, and probably if she do not use an effective contraceptive methods, if there is an unplanned pregnancy, unfortunately, there is much more possibility that we will end in a termination of pregnancy. Then we said there is a problem with conflicts in the decision making, because this is the norm. Remember, there is a strong ambivalence for women to be pregnant or not, to be on a method or not. I'm controlling my life or not. It's better to live to the partner. So many influence out there from many from the social media. This is something we have to consider very much, and also friends and family, they always say, happened to me this and that. And it's like when you are pregnant, okay? The people, they always give you suggestion on the way they deliver, and you should deliver like that. And this is not good, because you overload the woman with conflicting information and even misinformation. There is a lot of hormonophobia out there, and women, they are really disempowered, and so women, they feel even more anxious. And we know that if you have anxiety, then you will have a nocebo effect when you take a contraceptive hormone, for example, and so the decision making become increasingly complex and even paralyzing. So how we apply the evidence to everyday practice, and look at the following statements and phrase can help you to reassure the woman and understand how much she is in conflict in the decision to take or not a contraceptive, effective contraceptive option. So how we reassure the woman and create an atmosphere of empathy and understanding. Contraceptive choice has become an increasingly complex decision with a wide range of methods to consider. In this way, we offer so many choices. Deciding on the best method may involve several decision-making stages. This is another possibility. It can be challenging to decide on a method when information is overwhelming and may appear conflicting. In this way, we try to understand if the woman has all this information in her head. Then assess decisional conflicts and explore her feeling towards a decision-making approach. Do you feel overwhelmed by the number of contraceptive choices available to you? This is very important because, as you know, women, they know the pill and the pill should be. But maybe you have a pill, it's new, natural hormone, they get confused. Have you looked online or spoken to friends and family about their experience with different contraceptive options? This is very important because we know if we are doing a consultation with a third person, an elephant into the room. How do you plan to make your decision? Would you like to decide today, discuss it with your partner, family or friends, or do more research first? This is very important also. You don't put the pressure on the patient, on the woman, because sometimes she's not a patient. She's just a woman. She wanna do something for her life. And we really need to give the people time. So you see here some expert tips. When a woman is conflicted, we really must adapt our approach to build confidence in her choice and guide informed decision making. We have to validate our concerns. We don't have to be dismissed. Remember, acknowledging that deciding on a contraceptive method can be a complex decision for many reasons. The range of methods now available, external pressure, the volume of information from the environment. We really need to categorize the methods to make clear explanation. You see, in this situation, it can be really helpful to say, these are the good and bad of the short acting, these are the good and bad of the long acting methods, or hormonal or non-hormonal option to simplify the choices. And then we try to narrow down the recommendation to 2 or 3 appropriate choices that, keeping in mind their medical history, needs, and preference, can be proposed to the woman. And then we have the judgment, bias, and assumption. We really need to summarize the discussion, as I said, without being judgmental. And what the evidence shows, women often view the process of contraceptive counseling as more important than the outcome itself. This is very crucial. So, as an healthcare provider, unconscious influences such as personal preference, implicit bias, or assumptions can subtly shape the shared decision making discussion. What you did for your life is not what is good for your patient, and this is very important to keep in mind. We don't have to influence woman contraceptive choice too much. We really need to foster informed and autonomous decision making, and to do so, it's really essential to create that judgmental free consultation environment with that empathy and open mindedness I told you before. So we really need to apply the evidence to everyday practice. How we do? Everybody has his own personalized approach by asking women open-ended questions, listening attentively and carefully to their individual needs and preference. We really need to recognize the texture of the psychosocial environment, personal, cultural, or religious beliefs, because this is very crucial for women's view. Remember, planning reproduction, sexuality, they are very, very sensitive topics. And we really need to avoid assuming that those beliefs are or how they influence decision making. And then, at the end of the day, we have to provide scientifically balanced information on a range of suitable contraceptive methods, ensuring that your recommendations are guided by evidence and the women's specific needs rather than our personal preference or bias. And here you see some expert tips. We are human beings, and so we really need to control ourselves. And when we speak to women who have different opinion, it can sometimes be hard to step back and see the world through their eyes. But we really need to put ourselves in the shoes of the patient and consider that older generation, like myself, for example, we connect the contraception with empowerment, whereas many younger women nowadays, they are disconnected from this view. They don't understand the power of contraception, how you can feel free and equal to your partner by making this choice. So we must recognize The beliefs about contraception have changed significantly over recent years. And also, we have to be curious about understanding their point of view. Me too, always in the consultation, I'm surprised sometimes by my little girl. And we really need to approach our consultation with curiosity and openness to understand the new generation. It's very important to use neutral language, avoid stating that one method is better than another, because women, they don't feel they're taking the wrong decision, okay? We have to avoid assuming which method or option a woman may want based on their age, marital status, ethnicity, or socioeconomic background. And then, at the end of the day, we have to summarize key points from the conversation to ensure alignment and understanding. You can reflect the value of your patient, the beliefs of your patient, and the preference back to the patient itself, and ask if the summary feels accurate, and do you believe there is something else we have to discuss or clarify. And now I think we can go to the second step, and it's my pleasure to introduce your president, the president of ESC, Teresa Bombas from Portugal. And thank you for listening.
Thank you, Rossella. You have to stop sharing. I will sharing my slides. You have already stopped sharing yours?
Yeah.
Okay. So we are here for the second part of this webinar and about this part of counseling, and we understand and we learned for the first part of this webinar that this is an open discussion. The majority of the women that we have with us are not patients. They are just women looking for a way, a safe way, or to prevent unplanned pregnancy. And this is very important that we involve the woman in the discussion. And because if we involve the woman in the discussion, the woman will be part of the choice, and the choice of the method will be their choice. And another important thing that Professor Rossella told us is about the way how use the language, neutral language without misconception, open language central within the woman, and don't say that this is not important, this is not scientific information. So we have to use this opportunity to inform the woman, because if we inform well, when she gets home and be with her friends, she will give to the group and to the other woman a better information, and it will be good for her and for the people that have social life with this woman, that will be very well informed. So nowadays, and when we have to explore the methods and organize our decision and select the methods, it's very important, because nowadays it's not the scientific information that only is important for the woman. The scientific information they will get from us, but from a lot and other sources, and some of them are important and some of them are not so well informed. And there's a huge group of sources that increase the myths and misconceptions regarding hormones. So it's important that we discuss this with the woman in a balanced discussion, that we have to focus in physical, mental, and sexual health. So we have to choose a method that is suitable for the woman according with her health, but doesn't mean any complication and problems related with the health, physical, mental, and sexual health. So don't forget, because the woman expect for us that the choice will be safe, will be safe for her health, and if it's not a healthy woman, that the use of the method that increase the disease that women have, and we have to be in account too with the medication that women have done and is doing, and what about the past. And one thing that Professor Rossella said that I think is very important is sometimes the women have bad experience with other methods before, and this is very strong because they say, okay, I take the pill and I increase 10 kilos, it was terrible. Even we say, okay, we have different kinds of pills, we can choose another one, but this is very, very strong information. So I think we have to evolve and talk, question the last experience with hormonal methods or with other methods, the number of times that women have unplanned pregnancy, and what the situation they have unplanned pregnancy. Because one of important thing that I realized for my clinical practice is that women think that the contraceptive methods, especially the hormonal contraceptive methods, are 100 effective. So I take the pill and I get pregnant. How can it happen? So we don't have 100 effective methods, but in fact we have more effective methods than others. So the evidence shows that if we have these open questions and involve the woman and have a space for the woman, told us what is disturbing her, why they think the hormones are bad, and you show that is always a balance of risk and benefits, it will be easier, and this discussion will be easier. And it will be in the end it will be an increase of the information regarding the methods regarding the health. So we have to apply this everyday practice. Looks difficult, but it's not difficult. We have to do the right questions. So open discussion, no judgment, have a space for the woman, say what is disturbing her, and in the end, I think we can find a good solution for her. So, as Professor Rossella presents, we can discuss this, and in fact, we can open this discussion between myths and misconception. We have to discuss this, and we can ask in a very concrete answers, because the woman can say, I don't want to use hormones because hormones make increase the risk of cancer. And of course, we have to explain the woman what is a question of risk and benefits, and what means the risk, what means the risk in practical way. So we can show it with images the number of women that have increased the risk in a global number of the women. We have a lot of good images to this. So, and put this in a concrete way, compare the risk of breast cancer and the risk of have an accident when she drives every day, and the risk of having unplanned pregnancy if they use not a very effective methods, and how these hormones can contribute to the better quality of life. I think it's important to open this discussion, because in fact someone don't like to use hormones, but we have other methods without no hormones, and we can open the discussion to this kind of methods if is sweet for the woman. And in fact, this is a new approach that the topic of sexual life and mental life. This is a new approach in counseling. We never use, and it's difficult sometimes from some providers, focus in sexual health and mental health. But we have to be open and use this opportunity to check and to open discussion about sexual life, because some of the women can have some questions, can have some problems, and during this family planning appointment, it's a very good opportunity to screening this kind of situation, reference the woman of the couple to professionals that work in special in sexual health, or just to discuss with the woman the best approach to have a good or a sexual life that is good for her and his partner or her partner. And we have for us professionals that work in sexual health, sexual and reproductive health. It's very clear that quality of life imply sexual, physical, and mental. And it's important that the woman must protect all these conditions of their life. And as Rossella have already said, the women now, the young women, are important and important. And in fact, contraception contribute, but it's not a very strong situation, because for them, freedom of choice, equal opportunities is already there. And but of course, we have to focus and we have to think about that there's a huge group of women. In fact, this is not a reality, and we have to use this opportunity to discuss these topics. And of course, if you are not comfortable with open the discussion to sexual life, we can train ourselves in this topic. And it's not difficult, and it will be very useful for our day practice. And of course, we include all of these, but we cannot forget that there are something and very important topics of the health of the woman that we have to consider. We have to consider the risk of sexual transmitted disease. We have to counsel. We have to be in contact with obstetric and gynecologist story. We have to be in account with the fertility, the project of pregnancy, and the mood. And don't forget that some women have impact in the mood during ovulation period and during the premenstrual period, and they assume that is quite normal, but we can show her that in fact we can improve the mood during all cycle. And so this is the huge opportunity to have this discussion with the woman. And we can, and for us it will be easier if we open and normalize the discussion, and don't say, I'm just asking you this because you are in some condition. No, this is normal questions, and we have to open the discussion to all women. And if you are not comfortable, or if you don't want to discuss your sexual life, okay, we can move on. But if you want to discuss the impact of the contraception choice in your sexual life, and we have to think about it, because some of the women could have impact in their sexual life if they have afraid of pregnancy, and they are stressed at the risk of pregnancy, and this is a good opportunity to improve and choose a method very, very effective. And we know that in our clinical practice, we know that the evidence shows that this open, discussed, transparent, with benefits and risk always in a balance, it will be good, and it will be very practical in the way of the women organize their choice about contraceptive methods. And of course, we cannot forget the risks. We have to protect women's health. And one of the risks that is in the mind of the woman related with hormonal contraception is the thromboembolic risk. So always discuss the risk in a perspective. What are the number of women that in normal life could have a thromboembolic event? What are the situations that increase the thromboembolic event, and what are the best choice to protect the woman for a thromboembolic event? So we can use like image to explain to the woman what really are the risks, and put always in a perspective the risk and the benefits. How many women will be protected for unplanned pregnancy, comparing with the number of the women that could have a thromboembolic risk. So if we explain this, I think in the end, the woman will understand, and could have a better choice. And of course, as I said, we have to know well the medical eligibility criteria for choice of contraceptive method, and explain to the woman that all these things related to with hormonal contraception are well studied, and we know what are the situations where these methods combine hormonal only without hormones, are sweet to the woman and safe to the woman. And I think this is very important. So we have to be careful with medical story, with the family medical story, with events with other before in the life of the woman, and with the risks of the thromboembolic risks regarding the use of a method. And this is not so complicated, and it's easier to find, and does not take so much time. So we have to improve our knowledge, know well how these methods work, what are the risks of the different methods that we have in the market, and how we can tailor this method to the woman that we have with us, with her medical conditions, the risks, benefits, and about the expectations, and in the end, how we can contribute to improve the quality of life with women. We are not just talking about contraception, but we are talking also about quality of life. So the thromboembolic risk is the major stress in the mind of some women, but in fact they are afraid of the pill, but they are smoking, they are overweight. So we have to use this opportunity to discuss that thromboembolic risks are not related only with contraception, combined hormonal contraception. And nowadays we have safely hormonal methods, but maybe the woman have to look herself and check the other risk factors for thromboembolic risks. So the evidence shows us that with this kind of constructive counseling, I think we will help women to have a better choice and to improve her quality of life. So we don't need to press the woman, so we have to have a decision now. We have to give information to the woman, and they decide when she wants. And if she have questions, she can come back and we discuss again. If she wants to discuss with the partner, she will discuss with the partner. So it's not like you have to be out with the option. No, you have to be out of this appointment, and we with information. And if you want to have an option, of course, but if you want to think about it, we can return to this discussion again. So don't forget, it's not so complicated. Explore the health of the woman, explore the fears of the woman, be constructive with our information, always practical in risk and benefits, and in the end, respect the woman option and the woman feels what the woman feels about the information that we give to her. So now I will stop sharing my screen and I will introduce Professor Helena, and she will talk about the last part of this counseling. And after that, we will have the discussion. Thank you, Helena. The floor is yours now.
Yes. Thank you, Teresa, for that kind introduction. So I'm going to share my slides. There we go. Move everything so I can see myself. So thank you. And I think that made for a very nice sort of overview of everything that you have to do. And now I'm going to talk about evidence-based way of wrapping it all up. Because there are so many things that you need to do, but in the end, what's really important is to make sure that you have the patient on board. Many patients feel that the consultation is also about sort of pleasing the doctor. And we need to move away from that narrative and make sure that the patient really understands that this is all about her. So the third step is really about reassuring and revisiting, and also to normalize choice and change, because many women don't find the suitable contraceptive right away. It takes time. Sometimes I even tell my patients, you know, how you walk into a store and you find this beautiful shirt or trousers or whatever, and you're sure that you're going to love them. So you buy them, and then you come home and they are just lying there in your closet and you never use them again. And sometimes you feel like, oh, you don't want to walk into that store and give it back, or, you know, like you feel a bit like embarrassed that you bought these and they didn't really fit. But that is not it. This is all about the woman. So it should never be about us. It should always be about the woman, making her happy, making sure that she feels safe to come back, and that we will be there for her, even if she's not happy with her first choice, even if she feels she made a bad choice or that we recommended the wrong thing for her. We always have to make sure that she feels welcome back. So this is the final end of the consultation. And we are then reassuring the woman that it can take time to find the most suitable option, and that change is normal. A lot of women don't make it right the first time. We also need to make sure that the woman does not feel guilty. Both Teresa and Professor Nappi mentioned this, that there's so much information out there that if she comes back with like questions and things that she has found on the internet and wants to ask us things, that we make sure that she feels safe doing that. And we also need to assess her satisfaction with the consultation, and perhaps also schedule a follow-up if there's time for that, and if she wants to. But we here want to make sure that she feels welcome back. So again, change is normal. A lot of women don't make it right the first time. It's not a one-hit wonder, this contraception thing. You have to make sure that you feel welcome back and that it can change. And also acknowledge that this might feel a bit like frustration, that you don't immediately find your thing. Maybe you have to even try it many, many times, and it will take time to find a suitable method, going through several ones. And this may also result in discontinuation if you do not, as a healthcare provider, make sure that the woman feels welcome back. And that is what we want to avoid. And I also tell this to women. I say, like, well, listen, the worst thing that can happen is that you feel that this wasn't right, you don't feel that you can trust me, you don't want to come back to me, and you just quit. That would be the absolute worst case scenario, because I mean, ultimately they do come to us because they have a need for contraception. And here it's also good to explore how important it is for a woman to avoid an unplanned pregnancy and perhaps bring it up again to make sure that she feels motivated to try and to come back. And also that this method that she has now might be the right one for this time in her life, but that this may change. Things change, we evolve as human beings, we have different needs at different times in our lives, and that this contraceptive method that she chooses today might not be the one that she continues with for her whole fertile life. So it has been shown that fostering this kind of environment where change is normalized, it empowers women, and it makes them find more suitable method for them. Well, really, this slide is basically saying what I had to what I've already said. But I think that this compassionate and frankly interested sense that you are making, that you seem interested in the woman and really express that you want her best, is very good for this ongoing partnership that hopefully you will develop with this patient. And as I said, not only for now, but also for the future. These statements are the ones that you can, well, you heard me there with a shirt or the trousers, but you can also say like, well, there are many different methods to choose from, and it can take time to find what is right for you. And I think that most women acknowledge this fact. And I also usually say to women that it's not a coincidence that we have so many methods to choose from. We have so many methods to choose from because all methods don't suit the same women. And as I said, you may want to change the method throughout life as you evolve and as your needs develop. And if this method then does not feel right for you, that is okay. Please come back to me. I will make sure that you find a method that is most suitable for you. So that's really the first part. And then this is the sense making. And what usually happens is that even if women walk out of your office with a method, they want to do research. And they want to do research on their own. And you should be aware of this because this happens for everybody. So they're like, okay, I walk out of this office with this method. Now I want to find out if this is a good method. And what happens then? Again, women enter the internet. They talk to their friends. They talk to their family. They talk to whoever, husband. And I think this is very good that we acknowledge that this is going to happen. And that we also acknowledge both the positive and the negative information that women will find out there. And so sort of a preemptive strike, that means that you foresee something that is going to happen and try to reduce the harm that might possibly happen. It is a good way, for example, to say, like, I expect that you will look for information on the internet. Let me perhaps direct you to some reliable sources. Here are some examples of good websites in the country, wherever you are, where you know that there is reliable information about contraception. And also say that I understand that you will talk to your friends, but please do remember that your friends are not you. And this is usually what happens. And I also say, like, well, I have a lot of women coming into my office saying they want exactly what their friend is having because it works so well for their friend. But then in the end, that method does not work for them. And the easy answer to why is that they are not their friend. So anecdotes can absolutely perhaps help you to understand how other people experience the method that you have chosen, but might not necessarily help you realize what will happen to you. And then also acknowledge what kind of information is out there in the internet, both positive and negative information, and that usually the people who are negative about something will take up much more space than the people who are happy about something on the internet. And when you actually say this out loud to people, what usually happens is they say like, yeah, right, of course, yeah, you're right about that. Yeah, I'm going to think about that. Whereas if you don't say it, they might just, get carried away. So taking these things into account is very important and might make it easier when you see the patient next time. So again, this sense making, acknowledge that choosing a contraceptive may take time, emphasize the prevalence of misinformation online and the importance of critically evaluating sources, share your trustworthy sources of information. And of course, these sites should not be like, well, you can go on to PubMed or Medline or any other kind of medical sources. These should be like popular science information sites. And then the following part is about like coming back to you also. You don't have to make a decision today, but I'd be happy to give you even a few different prescriptions if that is what you want. If you haven't decided today, but you want to leave the office with a prescription, I can do that. And then you can go home and talk and decide. And please make sure that you use some kind of protection in the meantime so you don't have this unwanted pregnancy if that is the case. And of course, that this is your choice. This is all about you. I'm not here to sell you medication. I'm not here to sell me. I am here to make things good for you. And then also these, like, where do you perhaps plan to look for extra information? Because I understand that you would. I would too. I would talk to people. And then also evaluate sort of what they say to you and try to make them realize that there's both positive and negative information out there. Then the last part is about satisfaction with the consultation. And I think this is something that is very important for us as healthcare providers, that we always try to improve. So what went well? What didn't go well? Did you cover everything? Do they still have questions? Do they feel happy with you? Was there something that didn't work in this consultation? So in this way, we can all improve. And it's also quite satisfactory to actually know what the patient thinks about you. So that's the last part. And it could be like, well, after this consultation, do you feel happy with the contraceptive method that we discussed and the decision that you made? Or do you feel like, well, I don't know, maybe this was like the least bad one, but I'm not sure this will be right for me. Also, did the session align with your values, preferences, and needs? Do you feel safe? Do you feel that I acknowledged you, that I understood what was important for you? How satisfied are you with the information and support you received? Are you missing any information? Do you still have questions about the specific method or about any other method or just about side effects or anything like that? So these are the types of questions that you should really ask at the end. Are you happy about me? Do you feel confident that you can come back? Do you feel confident that I care about that this is for you? And this is sort of like a starting point to collect feedback. And I also want to make sure that everybody understands that, I mean, here we are speaking about like an hour about what you're supposed to do in a consultation. But in fact, we have shown that you can do all of this in 10 minutes because it's really about showing an interest and opening up. And if you do, the patient will automatically open up. So this does not take an hour to do, even though we talk an hour today. And then I think like after each consultation, or at least at the end of the day, it's important that we try to figure out if we are doing a good job. And Rossella said like, oh, I've had so much teaching. And if you have a student with you, that's a very good way of like, do you think that this went well? Could I have done anything differently? Or things like that. That's also a good way of doing it, or your nurse or whatever. And also, like I said, ask women for feedback at the end of the session. And this can perhaps help you improve next time, if not this one. And that is really what I wanted to say, because I wanted to make room for questions. And I think that the step 3 is really sort of like just wrapping the consultation up. and really takes the shortest time out of all these three. And here you can see the steps again: the plan and the listen, understanding needs and expectations, which is really about preparing for step 2, which is the actual consultation. And then step 3 is to make sure that the patient is happy with what you have done, understands, collecting the information, where will she go, and then also sort of this preemptive strike, understanding that she will find information that perhaps you haven't shared, that you chose not to share, things like that, and that she uses reliable sources for her information collection, and that she feels safe, that she can always come back to you if this method doesn't work, because most women perhaps need to change method. It's very seldom that you sort of strike right the first time. And as I said, even if you strike right the first time, this might not be the method that you want to use for your whole fertile life. So I will stop my sharing then, and then I hope that we have some time for questions.
Don't stop, Helena, because in your last slide are the key codes to QR codes
right.
you can download, where the people can download the material. So please maintain your last slide.
Yes, I'm sharing it again.
Because so this you have here the QR codes to access to the resources of all these materials. So could be important to the people that are our colleagues that are listening to us.
So, and then I think it's very important to say that this material, that you don't have to use all of it, that you can adjust it for your own practice, use one part of it. Perhaps you feel like you're really good with step 2, but you need to think more about step 1 and step 3, then you use those kinds. And so it's not like, yeah, you can use it any way you choose and any part you choose.
And of course, you have to adapt to the methods that you have in your country, the level of information that the women are, where you work, and the information that women have. So you have to adapt to the setting where you are working. Thank you, all of you. And thank you for the questions. We have already some questions here in the chat. The first one is from a colleague. Is a colleague that say hello from Italy, and the first question is for you, Rossella. How long does it take from you to do that counseling that you prescribe? Just consider the time that we have at doctor's office.
You know, in my dream, I tried to do it in 10 minutes because usually then you have other 5 minutes to do maybe the gynecological exploration, etc. Because it's true that we have 15 minutes average for contraceptive consultation. In my opinion, the most important aspects here is that, it's also crucial to give the woman the impression that you open the door, and if you're not able to finalize in that 10 minutes your final decision, the most important thing is to say, okay, you tried, and then maybe we can discuss further in the next appointment, or as you know very well now, women they like to send us an email, a WhatsApp to know what's going on, how it's going. But I think if you, practice, you can do it in 10 minutes. It's just a question of practicing.
Yes, I agree with Rossella. So if you have all of this in your mind, the questions and the situation are open, and it's not so complicated, and the time that we have for appointment are enough for the majority of the women. And I really think that if we train ourselves, the counseling will be much more effective in a small a period of time. This is my opinion. What do you think, Helena, about this time?
No, I mean we've had the counseling sessions in several congresses, and we have shown that it can be done in 10 minutes.
Yes.
And I think that most of the time people are just amazed at how much you can actually cram into 10 minutes if you do it in a structured way.
Yes.
Of course, that won't be true if you have a woman who has loads of concurrent diseases and has tried millions of different contraceptives and has heavy menstrual bleeding and fibroids and depression and things like that. Then of course it will take longer time, but that is not your everyday patient.
No.
Your everyday patient is a rather healthy woman, hopefully with a certain need. And then you can do this in 10 minutes. And you can even include this step 3, the reassuring and revisiting.
Yes.
And
Yes.
yeah.
My experience is really that we can do in the time that we have organized for the appointments. And the third question is related with risks. It's always difficult to talk about risks, and this question is very specific to the risk of breast cancer. How we explain the risk of breast cancer. And this is the same how we explain the risk of thromboembolic event, of how we explain the risks. I think it's different from country to country. And this I think it's, in my opinion and my experience, is different when we talk about absolute risk and the relative risk. And as I say before, I think it's for some group of women is very important to put it like in a picogram, when you can have in a group of women how many will have this complication. So in my view, for some group of women, when you talk about the increase of the number of it's important to show the numbers. How many women will have this in this group of women? This is my experience, and but I want to listen, Helena and Rossella, about this.
Well, I don't know.
Go.
Do you want to? You can start, Rossella, please.
No. But anyway, I think Teresa, you're right. Even though in my setting in Italy, I don't use even though they are useful, but I don't use so much because I didn't see the benefit really. Women sometimes they are confused that this pictorial, let's say 1,000 women with only one and a half colored. I always try to explain, listen, there is a subset of women that is very small, that it may be for them. Uh, the contraception is an additional promoting risk factors for breast cancer or thromboembolic risk. But remember that this risk is small. It really should be put in context with so many other risks. For example, for thromboembolism, I always made the example to stay hydrated, not smoking, and also that there are many thromboembolic events that don't have a clear cause. With breast cancer, I always try to make the example that even being a little bit overweight or eating some kind of foods or drinking alcohol, etc., is giving you a risk. So we have always to try to balance also with some benefits, and I always say, yes, maybe there is a risk, a little risk out there. We don't know if it's yours, but what is important is that you think about what you gain, because this is life. It's always a choice. It's always a risk taken, etc. And I can tell you that I feel women they are quite reassured. The one they are more resistant. The other one they have really maybe a mother that had breast cancer, a close relative, or a friend that have had a thromboembolic event.
Yes,
You know,
and
with
I think
can I say something?
yes,
With
please.
with breast cancer, I think it is very important, and I think that it's very important that people are made aware of how extremely common breast cancer is. And I say, like, I understand that you are afraid of breast cancer, and breast cancer is the most common cancer in women. And actually, during a lifetime, around 1 out of 10 women will get breast cancer. So this is a very common cancer, but you are still young because these women are young. We are talking about contraception. And that means that your risk of getting breast cancer is very small. Uh, whereas as when you get older, the risk of breast cancer will become much higher. But then I also say, like you do, Rossella, that it's probably much worse to have around 3 glasses of wine per week than to use contraception. And
Yes.
then people really are like, oh, you know. And nobody is afraid of drinking 3 glasses of wine per week, especially perhaps not in Italy and Portugal. But that really puts it into context. And it's the same with
Yes.
the thromboembolic risk. I say it's much worse to weigh 5 kilo more than to use contraception. And that also puts it into context because a lot of people walk around with a lot of weight, but they are not afraid of that. They don't think that they will get thromboembolism. But with contraception, people are so afraid. So I don't use the absolute risks, but I use the relative risk. And I use alcohol and I use weight. And I think that people can relate to. So that's just my way of doing it if you want to have my advice, even if perhaps you didn't ask for it.
And I think the relative risk it's very important, and we cannot forget that the big window of imagine thromboembolic risk is not the use of combined hormonal contraception, but is the pregnancy and postpartum.
Yeah.
And this is the big window in the life of a woman of thromboembolic risk. And in fact, we in obstetrician, we are now very active and prevent this risk because we have more obese women. But the women when get pregnant don't realize that this is the huge window of thromboembolic risk. It's not contraception, but is the pregnancy and postpartum. We have another question here. Is it still that the risk of breast cancer and progestin is inconclusive? So it's an open discussion. The breast cancer is related with the progestin compound and not with estradiol compounds.
I think that we all agree that it is the progestin that causes the breast cancer risk. And I think it's also very important to acknowledge that your own bioidentical progesterone that is produced by your own ovulation every month also causes an increased risk of breast cancer. But with the progestins that you use in contraception, you have it a longer time, and so you have an increase. But it is the progestin. But perhaps we will have new formulations in the future that reduce the risk of breast cancer, and the jury is still out on that. But I think that is what we should be hoping for.
And about new formulation, there's another question here that there's any idea when this 50 milligrams of mifepristone per week will be approved as a contraception method?
Well, the
You
studies are not large enough as it is to be
yes,
able
to
to
approve
register.
this.
So we need
More information
more
about
studies and
this.
larger studies.
Yes. To approve this as a contraception. And I think it's very important to say now in this time that when we look for contraception, in special hormonal contraception, we are not focused anymore in only in the prevention of pregnancy, but in the other improve the quality of life of the woman. So we have other benefits from hormonal contraception than prevent the pregnancy. And of course, there's a space for this new formulation and for maybe for mifepristone as a contraceptive method. But nowadays, with the formulation that we have, we can promote contraception and improve the health of the woman. It's not only a discussion on contraception.
I think we really have to finish now, but I want to address what Leah writes as the last question.
This is
if you
yes.
could leave with a pop, and I think that this is also, there have been studies on that sort of bridging with the progestin only contraception. If you sort of you have to examine risk factors, etc. And I do agree that when a woman comes to you with a need for contraception, the best thing is always if she leaves the office with a method. And if you have to look into risk factors, for example, if she thinks that maybe her father has had a blood clot or something like that, I think it's a good way to do it that you are describing here, to give them a progestin-only contraception as a bridging method until you can decide on a permanent method. Or like not a permanent, you understand what I mean, but
Yes.
so I think that's a very good reflection. Thank you, Leah.
Yes, but I think it's important to when we promote the progestin-only method, we have to discuss with the woman the impact in menstrual pattern, because some of the women are in some culture they did not accept the idea or don't have regular menstruation because they feel that it's not completely healthy. So for a woman who don't accept this, progestin-only method could be a problem.
Yeah, but as a bridging until they have decided. Absolutely.
So this is the reason why, in fact, we have a lot of methods. So we can individual the choices according with the culture and according with health conditions and the situation that we have in that phase of life. And Rossella, do you want to say something more to?
Yeah, this program is very beautiful, and we really need to go on doing the best research we can do to understand really how to shape the behavior to help women to understand, yes, sorry, but I have to say the power of contraception for your life and for your health. And I have to tell you that we really need to teach more to premenopausal women that contraception can be a great option to navigate also the menopausal transition, because the hormonal fluctuation, they can be even more dangerous than taking very low dose compounds. And nowadays that we have new option and natural estrogen, for example, they are so similar to what we can use also for low dose hormonal replacement therapy. This can be extremely great, and even the use of the IUD and containing progestogens, etc., etc. So there is really something more than contraception into the contraceptive choice, and we really need to help women to understand also this, because I think is important.
Yes, I agree with you, Rossella. So there's a huge way that we come from contraception, and we as providers have the power of prescription, and now we are doing decision including the woman and their needs. And of course, we know that contraception changed the place of the woman in the society. So now the couples can decide how many kids they have, if they want to have kids, and when they have. And of course, this is very, very important, because the opportunities for the woman in the society change with inclusion of contraception. And of course, we cannot forget that even in the generation when the woman live now with all the opportunities of contraception, with access to legal abortion and so on. So, but in fact, contraception, it's very powerful in their lives. The access to contraception is very powerful in their lives. Helena, any comments before we close this webinar?
Yes, I want to encourage you all to try it. Print out the material and say, I'm going to try this today. I'm going to try this for 3 consultations and see how it goes. Perhaps you will love it and change the way you work.
And what I realize is that we can try, and we will. The feeling in the end when we open the discussion with women is that we learn a lot about the world. That is a different world, and every woman have their own world, and we learn a lot, and is very important for our daily practice. This is not only about scientific knowledge, but it's social knowledge, and in the future we will be better providers. This is my opinion, but of course it could be different from other colleagues. But please try this program, and we can try with your residents, with your in your team. Try it with the midwife or nurses that we work together, that work with you. Don't forget, this is reproductive health and counseling. It's a teamwork. It's not an individual work. It's a teamwork. And all the providers that work with you have to have the same language. Otherwise, the woman will be confused with the information. So train this with your team. I don't think we don't have any more. There's one question.
No.
In which case, ethinyl estradiol still be indicated nowadays, because we have this is a difficult question, because we have now the new formulation with natural estradiol. Which cases?
We will see.
Helena, what do you think about it? There's still a place for combined hormonal contraception with synthetic ethinyl estradiol?
Yes, I think there will always be a place for that for women who need strong anti-androgenic properties for the contraception.
Yes.
So I think there will be room for all the formulations that we have, but I think there will be a shift in how much we use each method. I think there will be a shift towards natural estrogens, and but we will see. We will find the balance, but I think there will absolutely be a shift. But there will always be room for ethinyl estradiol.
Yes,
I agree.
I agree. We need to maintain ethinyl estradiol in the market, because they're a group for these, the women with need and potent and anti-androgenic, and the women who don't have good cycle control, and this is difficult for them with natural estradiol, because natural estradiol, some of the combinations don't have for some women don't have so good cycle control, and it's disturbing for her. But I'm glad that we have a lot of products in the market. So it's different choices, open opportunities, and it will be good. And I wish in the future that in all countries we can have all these methods, so the women have access to the same opportunities to have better counseling and better choices. And if we don't have anything more, I don't know if you want to say anything, or we can close this webinar from my side. Thank you for everyone to participate. I have to see all of you in Belgrade next year in a ESC Congress, and I want to thank to Gidi and Richard, to supporters in this program of counseling. So have a good time. Afternoon here in my country, afternoon in a majority of the European countries. But if you have another time, have a good rest of day. Thank you.
Thank you, everyone.
Thank you.
Bye.
Pleasure.